Hello everybody. Today we are going to discuss about the soft tissue infection in ICU. So in ICU commonly we are encountering with the cellulitis, necrotizing fasciitis and soft toxic shock syndrome. So we'll see how to deal with this. So cellulitis is an acute bacterial infection primarily of dermal lymphatics and subcutaneous tissue that most commonly affects the lower extremity, although it can affect other areas also. It causes the local signs of inflammation such as warmth, erythema, pain, lymphangitis, frequently systemic upset, impact with fever and raised WBC count. So pathogen involved in the cellulitis is streptococci and the staphylococcus aureus. So cellulitis associated with abscess is usually caused by Staphylococcus aureus. In contrast, typical, that is non-purulent cellulitis, is caused by both Streptococcus and Staphylococcus aureus species. So MRSA is the unusual cause of typical cellulitis. In neutropenic and immunocompromised patient, gram-negative bacteria should be considered. So the cultures of blood, cutaneous aspirates, biopsies, or swab are not routinely recommended. Cultures of the blood are recommended, and cutaneous and microscopic examination of cutaneous aspirate biopsy swab should be considered in patient with malignancy on chemotherapy, neutropenia, severe cell-mediated immunodeficiency, immersion injuries, and animal bites. So, typical cases of cellulitis without systemic signs of infection should receive antimicrobial agent that is active against the streptococcus. For cellulitis with systemic signs of infection, systemic antibiotics are indicated. So many clinicians could include coverage against the MSS. So for patient whose cellulitis is associated with penetrating trauma, evidence of MRSA infection elsewhere, nasal colonization with MRSA, injection drug use, purulent drainage, SIRS, vancomycin or other antimicrobial effective against both MRSA and streptococci is recommended. In severely immunocompromised patient, broad spectrum antibacterial coverage may be considered. Vancomycin plus either piperacillin tazobactam or imipenem meropenem is recommended as a reasonable empirical regimen for severe infection. The recommended duration of antimicrobial therapy is 5 days, but the treatment should be extended if infection has not improved within this time period. Elevation of affected area and treatment of predisposing factors such as edema, underlying cutaneous disorder are recommended. In lower extremity cellulitis, clinicians should carefully examine the interdigital toe spaces because of treating fissuring, scaling, and maceration may eradicate colonization with pathogen and reduce the incidence of recurrence of infection. Now, outpatient therapy is recommended for patients who do not have systemic inflammatory response syndrome, altered mental status, hemodynamic instability. And hospitalization is recommended if there is concern for deeper or necrotizing infection, for patient with poor adherence to therapy, for infection in severely immunocompromised patient, or if outpatient treatment is failing. Systemic corticosteroid, for example, prednisolone 40 mg for 7 days, could be considered in non-diabetic adult patient with cellulitis, but it has weak recommendation. Now, the treatment for non-purulent cellulitis. So, for non-purulent cellulitis, the treatment is penicillin 2 to 4 million unit every 4 to 6 hours. We can also use clindamycin in the dose of 600 to 900 mg every 8 hourly. Or we can use nafcillin 1 to 2 gram every 4 to 6 hourly. Cefazolin 1 gram every 8 hourly. Penicillin 250 to 500 mg every 6 hourly. And cefalexin 500 mg every 6 hours. So in community, there are also chances of community acquired MRSA in few patients. So carefully we should evaluate the history and we should identify those patients who are at the risk of community acquired MRSA. So these risk factors are immunocompromised status, personal and household contact with MRSA infection, or colonization in past 12 months, with prior antibiotic use for 5 days during the last 90 days, with cellulitis associated with penetrating trauma, especially from illicit drug use, or who do not respond to first line therapy, add one of the following oral antibiotics. So, if these risk factors are there, so then we need to consider the coverage for MRSA, like trimethoprim sulfamethoxazole every 12 hourly, minocycline 100 mg every 12 hourly, doxycycline 100 mg every 12 hourly, or if patient has beta-lactam allergy, then clindamycin 300 mg every 8 hours. So if the patient is admitted, then we need to start IV therapy in the form of vancomycin, that is 25 to 30 mg per kg loading dose, then 15 to 20 mg per kg every 12 hourly, linezolid 600 mg every 12 hourly in patient at a risk of gram-negative infection or severe form who do not respond to first-line therapy. Then we can go for piperacillin tazobactam 4.5 gram every 6 hours. Now, some patient might present with the recurrent cellulitis. So, in this patient, we need to identify what are the predisposing factors like edema, obesity, eczema, venous insufficiency, and toe web abnormalities. So these practices should be performed as a part of routine patient care and certainly during acute stage of cellulitis. So if these abnormalities are there, then we need to start the prophylactic antibiotic like oral penicillin or erythromycin BD for 4 to 52 weeks or intramuscular benzathine penicillin every 2 to 4 weeks in patients who have 3 to 4 episodes of cellulitis per year despite attempt to treat or control the predisposing factor. And this program should be continued so long as predisposing factor persists. So the bottom line is we need to first treat the predisposing factor, and if predisposing factors are there, then we need to treat the antibiotics for longer. We need to treat the patient with antibiotics for longer time, and means or the treatment should be continued till the presence of predisposing factors are there. Then this is the common scenario which we are encountering in ICU, that is the surgical site infection. So suture removal plus incision and drainage should be performed for surgical site infection. Adjunctive systemic antimicrobial therapy is not routinely indicated, but in conjugation with the incision and drainage may be beneficial for surgical site infection associated with the significant systemic response such as erythema and induration extending more than 5 centimeter from wound edge, temperature of more than 38.5 degrees Celsius, heart rate of more than 110 beats per minute, or WPC count of more than 12,000. A brief course of systemic antimicrobial therapy is indicated in patients with surgical site infection following clean operation on trunk, head, or neck or extremity that also have systemic site of infection. A first generation cephalosporin or antistaphylococcal penicillin for MSSA or vancomycin, linezolid, daptomycin, telavancin, or ceftaroline where risk of MRSA is high, that is nasal colonization, prior MRSA infection, recent hospitalization, recent antibiotic is recovered. Agent against the gram-negative bacteria and anaerobes such as cephalosporin or fluoroquinolone in combination with metronidazole are recommended for infection following operations on axilla, GI tract, perineum, or female genital tract. Now the next is Fournier gangrene. If we are encountering with the Fournier gangrene, then prompt surgical consultation is recommended. Empiric antibiotic treatment should be broad, that is vancomycin or linezolid plus piperacillin tazobactam or carbapenem plus ceftriaxone or metronidazole. Then penicillin plus clindamycin is recommended for treatment of documented group A streptococcal necrotizing fasciitis. Then if we are encountering with the Clostridium gas gangrene, then urgent surgical exploration of suspected gas gangrene site or surgical debridement of involved tissue should be performed. In the absence of definitive etiological diagnosis, broad spectrum treatment with vancomycin plus either piperacillin tazobactam, ampicillin sulbactam, or carbapenem antimicrobial is recommended. Definitive antimicrobial therapy with penicillin and clindamycin is recommended for the treatment of Clostridium myonecrosis. Hyperbaric oxygen therapy is not recommended. Then soft tissue infection with initial episode of fever and neutropenia. Hospitalization and empirical antimicrobial therapy with vancomycin plus anti-pseudomonal antibiotics such as cefepime, a carbapenem like imipenem celastine or meropenem or doripenem, or piperacillin tazobactam is recommended. It is recommended that treatment duration for most bacteria should be 7 to 14 days. Surgical intervention is recommended for drainage of soft tissue abscess after marrow recovery or for progressive polymicrobial necrotizing fasciitis or myonecrosis. Then adjunct colony stimulating factor therapy, granulocyte macrophage colony stimulating factor, and granulocyte transfusion are not routinely recommended. Acyclovir should be administered if you are if should be administered to patient suspected or confirmed to have cutaneous or disseminated varicella zoster virus infection. If somebody is presenting with the persistent or recurrent fever and if the patient is neutropenic, then consider the possibility of the fungal infection like yeast and mold and add empirical antifungal. Then necrotizing infection. Necrotizing fasciitis is the aggressive subcutaneous infection that tracks along the superficial fascia, which comprises all the tissue between skin and underlying muscle. So extension from the skin lesion is seen in most cases. The initial lesion can be trivial like minor abrasion, insect bite, injection site or boil. And small minority of patients have no visible skin lesion. So the initial presentation is that of the cellulitis, which can advance rapidly or slowly. Examination of the local site typically reveal cutaneous inflammation, edema, discoloration, gangrene, and anesthesia. A distinguishing clinical feature is the wooden hard induration of subcutaneous tissue. In cellulitis, subcutaneous tissues are palpable and yielding in fasciitis. The underlying tissues are firm, and there will be systemic feature of toxicity like fever and septic shock. Then bacteriology. In the monomicrobial form, the usual pathogens are Staphylococcus pyogenes and Staphylococcus aureus, Vibrio vulnificus, then hydrophobia and hydrophilia, and anaerobic streptococci, that is Peptostreptococcus. So infection with the staphylococci and hemolytic streptococci can occur simultaneously. Most infections are community acquired and present in the limbs with approximately two-thirds in the lower extremity. There is often predisposing conditions such as diabetes, AV, arteriosclerotic vascular disease, venous insufficiency with edema, venous stasis or venous insufficiency, ulcer or injection drug use. Cases of necrotizing fasciitis that arise after varicella or trivial injuries such as minor scratches or insect bite are usually due to Streptococcus pyogenes and far less commonly community acquired MRS. The mortality in patients with group A Streptococcus necrotizing fasciitis, hypotension, and organ failure is high, ranging from 30% to 70%. Some cases are associated with child delivery and involve the uterus or episiotomy site. Severe pain may be the initial clinical symptom with little cutaneous evidence due to deep infection. Polymicrobial infection is the most commonly associated with the four clinical settings. That is perianal abscesses, penetrating abdominal trauma, surgical procedures involving bowel, decubitus ulcer, injection sites in illicit drug users, spread from genital sites such as the Bartholin abscess, episiotomy wound, or minor vulvovaginal infection. Most of the organism originate from the bowel and genitourinary flora. Now, the diagnosis of fasciitis may not be apparent upon the first seeing the patient. Underlying cutaneous inflammation may resemble cellulitis. However, the feature that suggests the involvement of deeper tissue include severe pain that seems disproportionate to the clinical finding, failure to respond to initial antibiotic therapy, the hard wooden feel of subcutaneous tissue extending beyond the area of apparent skin involved. Systemic toxicity, often with altered mental status, edema or tenderness extending beyond the cutaneous erythema, crepitus indicating gas in the tissue, bullous lesion, and skin necrosis or echinosis. Now, diagnosis. In practice, clinical judgment is the most important element in the diagnosis. The most important diagnostic feature of necrotizing fasciitis is the appearance of subcutaneous tissues or facial plane at operation. The fascia at the time of direct visual examination is swollen, dull gray in appearance with the stringy area of necrosis, thin brownish exudate may be present. Extensive undermining of surrounding tissue is usually present. So several clinical scores are available, but they are have been proposed, but they are mainly used to exclude the infection. Now, what is the role of radiological imaging? Computed tomography or MRI may show edema extending along the facial plane, although the sensitivity and specificity of these imaging studies are ill-defined. So CT and MRI may also delay the definitive diagnosis and treatment. A definitive bacteriological diagnosis is best and gram stain of a deep tissue obtained at operation or by positive blood culture. Cultures of superficial wound may be misleading because result may not reflect the organism in deep tissue infection. So the useful test is direct needle aspiration of area of cutaneous inflammation that may yield fluid for gram stain and culture. So in suspected cases, a small and exploratory incision made in the area of maximum suspicion can be useful for excluding or confirming the diagnosis. Then we need to apply the gram stain of the exudate, which will demonstrate the pathogen. If that demonstrates gram positive cocaine chain, then that suggests the streptococcus. If it is a large gram positive cocaine in cluster, then that suggests the infection of staphylococcus aureus. If necrotizing infection is present, it will be obvious from the finding described above. If there is no necrosis on exploratory excision, the procedure can be terminated with very little risk or morbidity to the patient. And then next step for diagnosis is the biopsy for frozen section analysis, which may also be used to make the diagnosis. But if enough suspicion exists to do biopsy, the diagnosis is usually evident on the gross inspection without histological confirmation. So the suggestion is go for the biopsy only when there is a suspicion exists, or else it is for diagnosing necrotizing fasciitis, there is no need of biopsy because it is quite evident on gross examination. Now treatment. So surgical intervention is the primary therapeutic modality, and features suggestive of necrotizing fasciitis include the clinical findings which we have already discussed, then failure of apparently uncomplicated cellulitis to respond to antibiotic after reasonable diet, then profound toxicity in the form of fever, hypotension, advancement of soft tissue infection during antibiotic therapy, then skin necrosis with easy dissection along the fascia by blunt instrument or presence of gas. So most patients with necrotizing fasciitis should return to operating room 24 to 36 hours after first debridement and daily thereafter until surgical team finds no further need for the debridement. Antimicrobial therapy should be administered until further debridement is no longer necessary and the patient has improved clinically and fever has been absent for 48 to 72 hours. So this is the option for a treatment of necrotizing fasciitis. First line antimicrobial agent is piperacillin tazobactam, imipenem cilastim in the dose of 1 gram every 6 hourly, meropenem 1 gram every 6 hourly, artapenem 1 gram every 6 hourly, then cefotaxime 2 gram every 6 hourly, plus metronidazole 600 to 900 mg every 8 hourly. Metronidazole 500 mg 6 hourly or clindamycin 600 to 900 mg every 8 hours. So if it is a streptococcus infection, then we can go with the penicillin plus clindamycin. Penicillin we can use in the dose of 2 to 4 million unit every 4 to 6 hourly or clindamycin in the dose of 600 to 900 mg every 8 hours. If it is a Staphylococcus aureus infection, then go for nafcillin, that is 1 to 2 gram every 4 hourly, oxacillin 1 to 2 gram every 4 hourly, ceftazolin 1 gram every 8 hourly, vancomycin 30 mg per kg in two divided doses, clindamycin 600 to 900 mg every 8 hours. If it is a Clostridium species, then clindamycin plus penicillin. That is, clindamycin we can use in the dose of 600 to 900 mg every 8 hourly. Penicillin 2 to 4 million every 4 to 6 hours. Then Aeromonas hydrophilia can be treated with the help of doxycycline plus ciprofloxacin or ceftriaxone. So doxycycline we can use in the dose of 100 mg every 12 hourly, ciprofloxacin 500 mg every 12 hourly, or ceftriaxone 1 to 2 gram every 24 hours. In case of Vibrio infection, the treatment is doxycycline plus ciprofloxacin or cefotaxime. Doxycycline is 100 mg every 12 hourly, ceftriaxone 1 gram QID, or cefotaxime 2 gram TID. Then the next condition that we can encounter in ICU is toxic shock syndrome. So toxic shock syndrome is the severe life-threatening toxin-mediated condition, usually complicating invasive infection by either Staphylococcus aureus and group A Streptococcus, also called as Streptococcus pyogenes. So menstrual toxic shock syndrome is the Staphylococcus toxic shock syndrome, usually seen in female using high absorbent tampon. Other causes of Staphylococcus toxic shock syndrome includes complication associated with the use of barrier contraceptive, surgical wound infection, postpartum infection, burns, osteomyelitis, and sinusitis. Streptococcal toxic shock syndrome is caused by group A streptococcus and it is seen as a complication of soft tissue infection like cellulitis, necrotizing fasciitis, myositis. It can be also associated with other infection like pneumonia, thrombophlebitis, meningitis, endocarditis, septic arthritis, and endophthalmitis. The commonly implicated toxin are caused by Staphylococcus aureus include TSS toxin type 1, Staphylococcus enterotoxin B, and other rare one being entertained like A, C, D, E, H. With regard to group A Streptococcus, strain having M protein are more virulent and Streptococcus pyrogenic exotoxin A, B, C have been identified, which are responsible for shock and multi-organ dysfunction. Enterotoxin of Staphylococcus aureus and pyrogenic exotoxin of toothpaste streptococcus, they are superantigens. Colonization or infection with above mentioned organism is followed by production of the toxin, which are absorbed systematically that lead to the release of mediators like cytokines, interleukin 1, and tumor necrosis factor, which lead to the systemic manifestation of toxic shock syndrome. So toxic shock syndrome is characterized by the high-grade fever, rash, shock, and multi-organ failure, palmar and plantar desquamation, usually 1 to 2 weeks after the onset of illness. Other symptoms may include myalgia, vomiting, diarrhea, headache, non-focal neurogenic abnormalities, and symptoms related to primary disease. So, clinical features of streptococcal toxic shock syndrome, it consists of three phases. The first phase is the severe influenza-like illness present with the high-grade fever, chills, myalgia, headache with or without non-specific GI symptoms such as nausea, vomiting, diarrhea, and altered ventilation. Skin and soft tissue examination is essential to look for rash, tenderness, vesicles, or bulla. Second phase, there are systemic manifestations like tachycardia, tachypnea, and high fever. And third phase is the circulatory shock, which can present suddenly and may be of severe degree, and it is accompanied by the multi-organ failure. So the features of streptococcal toxic shock syndrome is the hypotension with multi-organ failure involving two or more of the following. That is renal impairment, coagulopathy, liver involvement, ARDS, generalized erythematous macular rash that may discommit, soft tissue necrosis, including necrotizing fasciitis or myositis or gangrene. And lab criteria include isolation of group A streptococcus. And the treatment, general principle of treatment of streptococcal and staphylococcus based on the management of severe sepsis, septic shock, and it involves supportive care, antimicrobial therapy, source control, and adjunctive therapy. So, antimicrobial therapies are streptococcal toxic shock syndrome caused by group A streptococci should be treated with combination of clindamycin plus penicillin. Now, why this combination is necessary? Because clindamycin act by suppressing production of streptococcal toxin and cytokine, and penicillin should be additionally administered because of possible resistance to group A streptococcus to clindamycin. As per IDSA, there is no evidence to prove efficacy of IVIG in the treatment of streptococcal toxic shock syndrome. So, in the suspicion of bacteriological diagnosis of Staphylococcus toxic shock syndrome, a beta-lactamase resistance anti-staphylococcal antimicrobial should be prescribed. Usually prescribed antibiotics include nafcillin, oxacillin, first-generation cephalosporin. For penicillin allergic patient or infection with MRSA, vancomycin can be added. Clindamycin can be added to therapy to reduce toxic shock syndrome TSST1 synthesis. Now, here are some newer antibiotics for treatment of gram-positive infection, which include fluoroquinolone class include delafloxacin, nemona, nemonofloxacin, levonordi and ala-levonordi. Then fluoroketolide include solithromycin, tetracycline include amidacycline and irawacycline. Then oxazolidinone include telizolid. Then the peptidyl deformylyl inhibitor include lanopeptidine. That's all. Thank you for kind attention.